Question 1. A 72-year-old male presents with a sudden onset of tearing chest pain that radiates to his back. His blood pressure is 210/110 mmHg in his right arm and 140/80 mmHg in his left arm. Which of the following conditions is most likely? A. Acute myocardial infarction. B. Aortic dissection. C. Pulmonary embolism. D. Pericardial tamponade. Answer: B. Aortic dissection. This question tests your ability to differentiate between causes of chest pain, with the key clues being tearing pain radiating to the back and a significant difference in blood pressure between arms, known as a BP differential. An aortic dissection occurs when the inner layer of the aorta tears, allowing blood to flow between the layers, which can cause this specific type of pain and unequal pulses or blood pressures. For example, if the dissection affects the brachiocephalic artery, blood flow to the right arm would be altered, causing the pressure difference. Remember this critical sign: a significant BP difference between arms plus tearing back pain should make you think of an aortic dissection immediately. Question 2. You are treating a patient with a suspected C3 spinal cord injury. Which of the following clinical findings would you most anticipate? A. Inability to move the lower extremities. B. Inability to feel sensation below the waist. C. Paralysis of the diaphragm. D. Priapism and warm, dry skin. Answer: C. Paralysis of the diaphragm. The core concept here is understanding the function of specific spinal nerves, particularly the phrenic nerve, which is crucial for breathing. The phrenic nerve, which controls the diaphragm, originates from the C3, C4, and C5 spinal roots. A high cervical spine injury at C3 can sever the connection to the diaphragm, leading to respiratory arrest because the primary muscle of breathing is paralyzed. Think of the rhyme to help you remember: C3, 4, and 5 keep the diaphragm alive, so an injury at or above this level is a catastrophic airway emergency. Question 3. A 6-year-old child presents with a low-grade fever, a seal-like barking cough, and stridor that worsens at night. The parents state the symptoms began gradually over a few days. Which condition is most likely? A. Epiglottitis. B. Anaphylaxis. C. Laryngotracheobronchitis, croup. D. Foreign body airway obstruction. Answer: C. Laryngotracheobronchitis, croup. This question focuses on differentiating pediatric respiratory emergencies, with the most telling signs being the seal-like barking cough and the gradual onset of a low-grade fever. Croup is a viral infection of the upper airway that causes swelling around the larynx, trachea, and bronchi, resulting in the characteristic cough and inspiratory stridor. Unlike epiglottitis, which is bacterial and has a rapid onset with high fever and drooling, croup develops more slowly. A great tip is to associate the barking seal cough directly with croup, as it's a classic and unique finding. Question 4. You are managing a patient in refractory ventricular fibrillation. After the third shock, what is the next appropriate medication and dose to administer? A. Lidocaine 1.5 mg per kilogram 4/IO. B. Epinephrine 1 mg, 1:10,000 4/IO. C. Amiodarone 300 mg 4/IO. D. Magnesium sulfate 2G 4/IO. Answer: C. Amiodarone 300 mg 4/IO. This scenario tests your knowledge of the ACLS cardiac arrest algorithm for shockable rhythms like ventricular fibrillation, VFib, that don't respond to initial defibrillation and epinephrine. After the third shock, the next priority medication is an antiarrhythmic, with amiodarone 300 mg 4/IO push being the first-line choice. If VFib persists, a second, smaller dose of 150 mg can be given later. Think of the ACLS algorithm as a structured sequence: shock, CPR, epinephrine, shock, CPR, and then it's time for the antiarrhythmic like amiodarone. Question 5. An 18-year-old male was stabbed in the chest. He is anxious, hypotensive, and has muffled heart sounds and jugular venous distension. These findings are most indicative of which condition? A. Tension pneumothorax. B. Massive hemothorax. C. Pericardial tamponade. D. Flail chest. Answer: C. Pericardial tamponade. The concept being tested is the recognition of Beck's triad, a classic set of signs for pericardial tamponade. The triad consists of hypotension, low blood pressure, muffled heart sounds, and jugular venous distension, JVD. In this case, the stab wound likely caused blood to fill the pericardial sac, the sac around the heart, which compresses the heart and prevents it from filling properly, leading to these specific signs. An easy way to remember this is to connect the 3 in triad to the 3 hallmark signs: JVD, muffled heart sounds, and hypotension. Question 6. A 55-year-old patient with a history of alcohol abuse presents with confusion, vomiting, and deep, rapid respirations. A fingerstick glucose reads high. Which of the following conditions is most likely? A. Hypoglycemic crisis. B. Ischemic stroke. C. Septic shock. D. Diabetic ketoacidosis, DKA. Answer: D. Diabetic ketoacidosis, DKA. This question assesses your ability to recognize the signs of DKA, a life-threatening complication of diabetes. The key indicators are the altered mental status, high blood glucose reading, and a specific breathing pattern known as Kussmaul respirations, the body's attempt to blow off excess acid, ketones, as CO2. These deep, rapid breaths are a direct physiological response to the severe metabolic acidosis present in DKA. Always remember that Kussmaul respirations combined with hyperglycemia are a hallmark presentation for DKA. Question 7. You are assessing an adult patient's end-tidal CO2, EtCO2, waveform and notice it has a shark fin appearance. This finding is most characteristic of A. Hyperventilation. B. Bronchoconstriction. C. Esophageal intubation. D. Pulmonary embolism. Answer: B. Bronchoconstriction. This question tests your interpretation of capnography waveforms, which provide critical information about ventilation and perfusion. A normal capnogram has a rectangular shape, but a shark fin appearance, where the upstroke is sloped instead of steep, indicates an obstruction to exhalation. This is most commonly seen in conditions causing bronchoconstriction, such as asthma or COPD, as air is trapped and exhaled slowly and unevenly. To remember this, think of the shark fin rising slowly out of the water, just as the CO2 rises slowly on the monitor during an asthma attack. Question 8. A 60-year-old female is in supraventricular tachycardia, SVT, with a heart rate of 180. She is pale, diaphoretic, and has a blood pressure of 80/50 mmHg. What is the most appropriate initial treatment? A. Administer adenosine 6 mg rapid 4-push. B. Perform synchronized cardioversion at 100 joules. C. Administer amiodarone 150 mg over 10 minutes. D. Attempt vagal maneuvers. Answer: B. Perform synchronized cardioversion at 100 joules. The concept here is differentiating stable versus unstable tachycardia and choosing the appropriate intervention. The key clues are the patient's signs of poor perfusion, pallor, diaphoresis, sweating, and hypotension, which classify her as unstable. While adenosine is the correct medication for a stable patient in SVT, electrical therapy, specifically synchronized cardioversion, is the immediate, definitive treatment for any unstable tachycardia where the patient has a pulse. A good rule to follow is, if a fast heart rate is making the patient unstable, electricity is the answer. Question 9. You are called to a 25-year-old pregnant female at 34 weeks gestation who is actively seizing. Her blood pressure is 180/110 mmHg. This presentation is most consistent with A. Eclampsia, B. Placenta previa, C. Abruptio placentae, D. Gestational diabetes. Answer: A. Eclampsia. This question asks you to identify a specific obstetric emergency based on classic signs. Eclampsia is defined as the onset of seizures in a pregnant woman with preeclampsia, a condition characterized by high blood pressure. The combination of pregnancy, hypertension, high blood pressure, and active seizures is the textbook presentation for eclampsia, which is a life-threatening emergency for both mother and baby. A simple way to keep it straight is, preeclampsia is hypertension during pregnancy, and when seizures are added, it becomes eclampsia. Question 10. A 45-year-old male has a Glasgow Coma Scale, GCS, score of 7 after a head injury. His pupils are unequal. You are preparing for rapid sequence intubation, RSI, and plan to administer a sedative. Which of the following is an appropriate induction agent for this patient? A. Ketamine, B. Fentanyl, C. Etomidate, D. Succinylcholine. Answer: C. Etomidate. This question tests your knowledge of RSI pharmacology, specifically choosing a hemodynamically stable induction agent for a patient with a potential head injury. Etomidate is often preferred in this setting because it has minimal effect on blood pressure and is considered hemodynamically neutral, which is critical for maintaining cerebral perfusion pressure in a patient with a head injury. While ketamine can be used, it may increase intracranial pressure, and succinylcholine is a paralytic, not an induction, sedative, agent. A key takeaway is that in head-injured or trauma patients, maintaining a stable blood pressure is paramount, making etomidate a very safe choice for sedation during intubation. Question 11. During a multi-casualty incident, you encounter a 30-year-old male who is breathing at a rate of 40 breaths/min. According to the START triage system, how should you categorize this patient? A. Minor, green, B. Delayed, yellow, C. Immediate, red, D. Deceased, black. Answer: C. Immediate, red. This question assesses your application of the START, Simple Triage and Rapid Treatment, triage system, which uses simple physiological parameters to categorize patients quickly. One of the first steps is to assess respirations. According to START triage protocols, any adult patient with a respiratory rate greater than 30 breaths per minute is immediately tagged as red or immediate because tachypnea is a sign of significant distress or shock. Remember the simple mnemonic RPM, respirations, perfusion, and mental status, and the cutoff for respirations. If it's over 30, they're red tagged right away. Question 12. A patient with a history of atrial fibrillation presents with a rapid, irregularly irregular heart rhythm at a rate of 140, accompanied by dizziness and mild shortness of breath. Her blood pressure is 110/70 mmHg. What is the most likely rhythm? A. Atrial flutter with a variable block. B. Sinus tachycardia. C. Atrial fibrillation with rapid ventricular response, RVR. D. Ventricular tachycardia. Answer: C. Atrial fibrillation with rapid ventricular response, RVR. This question tests your ability to identify a common tachyarrhythmia based on its key characteristics. The phrase irregularly irregular is the classic description for atrial fibrillation, AFib, where the atria quiver chaotically instead of beating effectively. When the ventricular rate is over 100 beats per minute, it is called AFib with rapid ventricular response, RVR, which often causes symptoms like dizziness due to decreased cardiac output. For exams, whenever you see irregular, your first thought should always be atrial fibrillation. Question 13. A 68-year-old male involved in a motor vehicle collision has paradoxical chest wall movement on the right side. He is becoming increasingly hypoxic and anxious. What is the most appropriate initial intervention? A. Apply a bulky dressing taped on 3 sides. B. Perform a needle decompression. C. Provide positive pressure ventilation with a BVM. D. Place the patient on his injured side. Answer: C. Provide positive pressure ventilation with a BVM. The core concept here is the management of a flail chest, which is identified by the paradoxical chest wall movement where a segment of the rib cage moves opposite to the rest of the chest during respiration. This condition severely impairs breathing, and the definitive pre-hospital treatment is to assist ventilations with a bag valve mask, BVM. The positive pressure from the BVM essentially acts as an internal splint, helping to stabilize the flail segment and improve oxygenation. Remember, while bulky dressings used to be taught, the modern standard of care for respiratory compromise from a flail chest is positive pressure ventilation. Question 14. You are treating a patient in anaphylactic shock with severe respiratory distress and a blood pressure of 70/40 mmHg. Which medication, dose, and route is the first-line treatment? A. Diphenhydramine 50 mg 4. B. Albuterol 2.5 mg via nebulizer. C. Epinephrine 0.3 mg 1:1000 IM. D. Solomedrol 125 mg 4. Answer: C. Epinephrine 0.3 mg 1:1000 IM. This question tests the critical first step in managing life-threatening anaphylaxis. The key indicators are severe respiratory distress and hypotension, shock. The single most important and immediate treatment is epinephrine, which reverses bronchoconstriction, reduces swelling, and increases blood pressure. For anaphylaxis, the preferred initial route is intramuscular, IM, because it's absorbed quickly and is easier to administer than in 4-line in a hypotensive patient. While other medications like antihistamines and steroids are helpful, they are secondary treatments and do not work as rapidly as epinephrine to reverse life threats. Question 15. A 40-year-old male was found unresponsive after a fall from a ladder. He has a heart rate of 40 bpm, a blood pressure of 82/50 mmHg, warm and dry skin, and is breathing shallowly. Which type of shock is most likely present? A. Hypovolemic shock. B. Cardiogenic shock. C. Neurogenic shock. D. Septic shock. Answer: C. Neurogenic shock. This scenario tests your ability to recognize the unique presentation of neurogenic shock, often caused by a high spinal cord injury. The classic signs that differentiate it from other types of shock are hypotension combined with bradycardia, a slow heart rate, and warm, dry skin below the level of the injury. This occurs because the injury disrupts sympathetic nerve pathways that control heart rate and blood vessel tone, leading to vasodilation and a slowed heart rate, unlike the tachycardic and cool skin presentation of hypovolemic shock. Think of neurogenic shock as the odd one out. It's the only type that typically presents with a slow heart rate and warm skin. Question 16. A 75-year-old patient is found to be in a third-degree AV block with a heart rate of 34 bpm. He is pale, confused, and has a blood pressure of 88/60 mmHg. After atropine is ineffective, what is the next most appropriate intervention? A. Adenosine 6 mg rapid 4 push. B. Transcutaneous pacing. C. amiodarone 150 mg for infusion. D. Synchronized cardioversion. Answer B. Transcutaneous pacing. This question focuses on the management of symptomatic bradycardia, specifically a high-degree heart block. The patient's confusion and hypotension indicate that the slow heart rate is causing poor perfusion. When atropine, the first-line drug for symptomatic bradycardia, is ineffective, especially in high-degree blocks like a third degree, the next step is to use transcutaneous pacing, TCP, to electrically stimulate the heart to beat at a faster, more effective rate. Pacing provides an external electrical signal to restore adequate cardiac output. The key takeaway is, for unstable bradycardia that doesn't respond to atropine, pacing is the answer. Question 17. A 28-year-old male has a traumatic brain injury and begins to exhibit Cushing's triad. Which of the following sets of vital signs represents this triad? A. Hypotension, tachycardia, and irregular respirations. B. Hypertension, bradycardia, and irregular respirations. C. Hypotension, bradycardia, and rapid respirations. D. Hypertension, tachycardia, and shallow respirations. Answer B. Hypertension, bradycardia, and irregular respirations. The concept here is recognizing Cushing's triad, a set of 3 clinical signs that indicate a critical increase in intracranial pressure, ICP, often preceding brain herniation. The triad consists of hypertension, specifically with a widening pulse pressure, bradycardia, a slow heart rate, and an irregular breathing pattern, like Cheyne-Stokes respirations. The body increases blood pressure to try to force blood into the compressed brain, which in turn triggers a baroreceptor reflex that slows the heart rate. A simple way to remember it is that Cushing's triad is the opposite of shock, high BP and low heart rate, signaling a brain in big trouble. Question 18. You are using a length-based resuscitation tape, Broslow tape, to determine equipment sizes for a 4-year-old in cardiac arrest. The tape indicates the child is in the purple zone. This information helps you determine A. The child's exact weight in kilograms. B. The underlying cause of the arrest. C. The appropriate medication dosages and equipment sizes. D. The likelihood of survival. Answer C. The appropriate medication dosages and equipment sizes. This question assesses your understanding of the purpose and function of the Broslow tape in pediatric emergencies. The tape is a color-coded system that estimates a child's weight based on their length, and each color zone provides pre-calculated medication doses, defibrillation energy levels, and appropriate sizes for equipment like endotracheal tubes and 4 catheters. Its main goal is to reduce the risk of medication errors and save time during a critical event by providing standardized, weight-based information quickly. Think of the Broslow tape as a cheat sheet for pediatric emergencies that links a child's size directly to the life-saving numbers you need. Question 19. A 30-year-old female in her 3rd trimester of pregnancy is in cardiac arrest. To maximize the effectiveness of chest compressions, what specific action should be taken? A. Perform compressions at a rate of 120 to 140 per minute. B. Manually displace the uterus to the left. C. Place a rolled towel under her right hip. D. Increase compression depth to 3 inches. Answer B. Manually displace the uterus to the left. The core concept here is managing maternal cardiac arrest, which requires a specific modification to standard CPR due to aortocaval compression. In a pregnant patient past 20 weeks gestation, the large uterus, gravid uterus, can compress the aorta and inferior vena cava when she is lying flat, severely reducing blood return to the heart and making CPR ineffective. Manually displacing the uterus to the patient's left side relieves this pressure, improves venous return, and significantly increases the effectiveness of chest compressions. Remember this critical step. In late-stage pregnancy arrest, you must get the uterus off the major blood vessels for CPR to work. Question 20. A 65-year-old male with a history of CHF calls 911 for severe shortness of breath. You find him in a tripod position with bilateral crackles in his lungs and pitting edema in his legs. His SpO2 is 86% on room air. The most appropriate initial treatment is A. High-flow oxygen via a non-rebreather mask. B. Continuous positive airway pressure, CPAP. C. Albuterol nebulizer treatment. D. Furosemide 40 mg 4. Answer, B. Continuous positive airway pressure, CPAP. This question tests the best initial management for acute cardiogenic pulmonary edema, where fluid backs up into the lungs due to heart failure. The key signs are severe dyspnea, crackles, rales, and low oxygen saturation. While oxygen is necessary, CPAP is superior because it provides positive pressure that helps push fluid out of the alveoli, air sacs, and back into the capillaries, while also keeping the alveoli open, which drastically improves gas exchange and reduces the work of breathing. Think of CPAP as a non-invasive way to splint the airways open and actively reverse the fluid shift in the lungs. Question 21. A patient presents with a history of a deep vein thrombosis, DVT, and is now experiencing a sudden onset of sharp chest pain, shortness of breath, and tachycardia. What condition should you have a high index of suspicion for? A. Myocardial infarction. B. Pneumothorax. C. Pulmonary embolism. D. Aortic dissection. Answer, C. Pulmonary embolism. This question tests your ability to connect a patient's risk factors and history to their current presentation. The key clue is the history of DVT, as a piece of the blood clot from the leg can break off, travel through the bloodstream, and become lodged in the pulmonary arteries, causing a pulmonary embolism, PE. The classic symptoms of a PE, sudden chest pain, dyspnea, shortness of breath, and tachycardia, are a direct result of this blockage. Always maintain a high index of suspicion for a PE in any patient with these symptoms, especially if they have risk factors like a recent DVT, surgery, or prolonged immobility. Question 22. You are transporting a patient with a confirmed ST elevation myocardial infarction, STEMI, in leads 2, 3, and AVF. Which of the following is a common complication you should anticipate with this type of MI? A. Hypertensive crisis. B. Left-sided heart failure. C. Bradycardia and hypotension. D. Atrial fibrillation. Answer, C. Bradycardia and hypotension. The concept being tested is understanding the location of a myocardial infarction based on EKG leads and its associated complications. Leads 2, 3, and AVF view the inferior wall of the heart, which is primarily supplied by the right coronary artery, RCA. The RCA also supplies blood to the SA and AV nodes in most people, so an inferior wall MI can disrupt the heart's electrical conduction system, often leading to bradycardia, slow heart rates, and various heart blocks. This can also lead to hypotension due to right ventricular involvement. So, when you see a STEMI in leads 2, 3, and AVF, be prepared for a slow heart rate and a drop in blood pressure. Question 23. A 19-year-old male is found unresponsive with pinpoint pupils and a respiratory rate of 6 breaths per minute. His friends state he was partying. Which medication is most indicated? A. Flumazenol. B. Sodium bicarbonate. C. Glucagon. D. Naloxone. Answer, D. Naloxone. This question requires you to recognize the classic triad of an opioid overdose and know the appropriate antidote. The combination of unresponsiveness, CNS depression, respiratory depression, slow breathing, and pinpoint pupils is highly indicative of an opioid overdose from drugs like heroin or fentanyl. Naloxone is an opioid antagonist that works by binding to opioid receptors and reversing and blocking the effects of other opioids, rapidly restoring respiratory drive. Remember the triad: respiratory depression, altered mental status, and pinpoint pupils, as the telltale sign for an opioid overdose requiring naloxone. Question 24. A 62-year-old male is in ventricular tachycardia with a pulse. He is awake and alert with a blood pressure of 130/80 mmHg and a heart rate of 160. According to ACLS guidelines, what is the most appropriate initial treatment? A. Immediate synchronized cardioversion. B. Administration of an antiarrhythmic medication. C. Defibrillation at 200 joules. D. Chest compressions and BVM ventilation. Answer: B. Administration of an antiarrhythmic medication. This scenario tests your ability to manage a stable patient in ventricular tachycardia, VTach. The key is to assess for stability. Because the patient is awake, alert, and has a stable blood pressure, he is considered stable. For stable VTach with a pulse, the treatment is pharmacological, involving an antiarrhythmic drug like amiodarone or procainamide to convert the rhythm. Synchronized cardioversion is reserved for unstable patients, and defibrillation is only for pulseless patients. The simple rule is, if they have VTach with a pulse and are stable, use drugs first. Question 25. You are called for a 30-year-old female who just gave birth at home. You notice the umbilical cord is protruding from the vagina, but the baby has not yet delivered. The fetal heart rate is dropping. What is your most critical immediate action? A. Encourage the mother to push forcefully. B. Attempt to gently push the cord back into the vagina. C. Place the mother in a knee-chest position and apply gentle pressure to the presenting part. D. Clamp and cut the umbilical cord immediately. Answer: C. Place the mother in a knee-chest position and apply gentle pressure to the presenting part. This question addresses the management of a prolapsed umbilical cord, a true obstetric emergency. A prolapsed cord occurs when the cord comes out before the baby, and it can become compressed between the baby's presenting part and the birth canal, cutting off oxygen supply. The most critical intervention is to relieve this pressure by having the mother assume a knee-chest position, or Trendelenburg, and using a sterile gloved hand to gently lift the baby's head or presenting part off the cord. This maneuver must be maintained until delivery at the hospital. Think of this as the one time you must physically intervene internally to save the baby's life by relieving pressure on its lifeline.